Right, yes, as we promised, we talking about the examination of the breast, and the command usually that you get on at your examination station would be how to examine the breast. It would not say the right breast or the left breast, and since this is a superficial structure, so we need to know about something. When you are talking about specifically about a breast lump or a breast ulcer or examination of the breast, you must always understand that by the end of the examination, what this examiner wants from you. Whenever you are examining a patient coming to you in your clinic with a suspicious lump in the breast, we need to know what is the whether this is malignant, whether there is a lump. One, if there is a lump, whether this seems to be malignant or is benign. If it is malignant, then we need to really stage the disease. So we need to know the T, which is the three-dimensional structure. So remember, it has to be the length into breadth into height, or if it is an ulcer, so it has to be length into breadth into depth of the ulcer. And we need to know its all that is required about its relation with the fixity with the dominant structures, with the skin, PDR skin, or any other associated abnormality that you can find with that T part. So you no need to know about the T1, T2, T3, and T4, and how does they are classified according to the AGCC, and that would help you in actually completing your examination. You are not going to miss anything once you know that something is going to be done. Second is the nodal status. I mean, you need to know what is N naught, what is N none, N1, N2, and N3. So when you know जब आपको पता है कि N1, N2 क्या है, so you automatically go on and see each station where you need to find them. So सारे groups जो से हैं, so medial group, anterior group, apical, and the central group, all the groups that are there. So you are going to examine all of these centers. So do not forget any one center that is not needed. So that would give you the N. So we have a T and we have an N, and then we need to know where does it metastasize. So if I know if I know that the tumor, if it is malignant and is metastasized to the systemic system, so it metastasizes to the abdomen, liver. So I need to include the examination of the abdomen in my examination. Then it can go to the lungs. So I need to auscultate the lungs, and it can go to the exoskeleton. So I need to palpate and then percuss the exoskeleton as well. So let's start with the examination. Always remember, whenever you get an impression, when you get command and it says examination of the breast, this means upright, you need to go and do 10 things while you are examining them. This is 10 things for inspection, 10 things for palpation, and then we'll move on. I'll let you know how can we'll move on. How does the position setting? You can examine the patient according to your protocol. It can be sitting position with the breast lump is away from the body. It is again the semi-reclined position or a supine position. If you want to ask the patient to and examine the patient in a supine position, it is recommended that you put a pillow under the same side, the shoulder, so that the whole of the tissue comes onto the trunk and not any part of it. Why it's important? Because in the breast tissue, more often when you are examining the anterior surface, you are actually palpating the posterior fold, and once you examine that posterior fold and you press on that fold, so you feel that there is probably a mass under it. So it has to be fat. There should be no folds. So if there are no folds, so it would be fat onto the body. So you need to turn the body according to your needs. So if it's a small size breast, so probably smaller pillow would do. For a bigger one, you need to turn the patient to the opposite side. Exposure, we need to ask the patient to undress up to the umbilicus. Initially, I always say that when you have got two organs, both of them needs to be confirmed before start of the examination of the normal breast of the breast. So first you need to inspect those 10 things in the normal breast, inspect all those things in the normal breast, and you need to tell the patient why are you doing it on that. Okay, so one, two, three, four, and five. So what do I need to do for the first five things? It comprises the four quadrants. So I have the one, two, three, and four quadrants, and the areolar complex in the middle. Like just go and see. What are you going to see? Five things. You need to see five things. For any swellings, so we start with the nipple and areola complex. We need to inspect on the normal size and then the abnormal side or suspicious side, whether for any. So the first are five things that you need to inspect in a patient where you're going to inspect upfront. Patient is sitting now in the normal position or lying down spine are the five areas that we need to look after. The first thing of these is the nipple areolar complex. You need to inspect the nipple areolar complex with the normal side, with the abnormal side, or vice versa. For any abnormality, is there an ulcer there? Is the shape is comparable on both sides? Are there any bleeding points? Is there any discharge? Is there any slit-like structures? Are there any previous scar marks there? And is there any expression of milk, blood, or abnormal colored serous material from that area? We also inspect the upper outer quadrant, then the inner lower inner quadrant, the upper inner quadrant, and the upper outer. So these things that you need to inspect, and then when you do palpate, you do the same things with the palpation. But for the time being, you complete the same inspection for all these things. What are the things that you are going to see in all of these areas? Is you need to see inspect for pudoric skin, for any visible mass, for any visible ulcer, for any visible scar marks, wounds, weeping ulcers, discharge from there, any abnormality, asymmetry, and these 4 or 5 things you need to again see for all 4 quadrants one by one. Once you complete the inner and the outer lower quadrant, you come on to the inner quadrant, then the upper inner quadrant, and the upper. When these 5 areas are done, we move on to the six. Six is the auxiliary. Do not forget to inspect during inspection, and then during palpation you need to palpate the same areas as you would palpate the same with the all 4 quadrants that you have just mentioned. Once these six areas have been inspected, right, I'm again saying inspected on both sides, now you can move on to the limb, or you can complete the palpation of the breast first, and then you can move on to the go on to the axilla, the seventh, eighth, ninth, and tenth that I'm going to this. What are you going to examine when you are talking about palpation and of the quadrants? So one thing is that you need to do the palpation with the flat of the hand. It is not done by the fingers. It is done by the flat of the hands. So you need to just do it like this, turn it, and you find that there is a lump there, or there is a abnormality, there is a thick tissue, like a fibroadenoma, a breast mouse, anything. So you need to just examine that. You need to be very careful about when you examine. अगर आप उसको एग्जामिन ठीक तरह से नहीं करते, अगर आप उसको ठीक तरह से रोल नहीं करते, so आप ठीक तरह से you are not going to identify. Why on the normal side? Again, you are examining the normal side because you need to know the exact consistency of the organ of that patient because they are different in different ages and different people. तो यहाँ से आप उसको जब उसको पैलपेट करते हैं तो पैलपेट करने के ऊपर आपको पता चलेगा कि इस पेशेंट की नॉर्मल क्या है, नॉर्मल कंसिस्टेंसी ब्रेस्ट टिश्यू की क्या है, ब्रेस्ट मास, and then you can compare it with the opposite side. So we do the same thing. If you find what would happen if you find that there is a lump, if you find that there is a lump there or there is an abnormality in and it is fixed, so immediately there is a box pops out and you need to do everything that is there for the for a swelling. So discuss it in a bit later or an ulcer. So you complete the inspection and palpation of the breast on both sides. We have done 5 things with the breast itself. So the nipple areolar complex, we talk about the 4 quadrants and then the axillary tape. 1, 2, 3, 4, 5, and then 6. There we go. Now what? Now is the 7. 7 is the axilla, very important. The T is completed, and now we move on to the N. Now, N again, we need to know it is N naught, N1, N2, and N3. Mota mota yaad kar leंगे. So the basic concept is 1, 2, and 3. You need to see whether there is the axilla is positive, whether are there any lymph nodes in the axilla. If there are, which group? Are they discrete, or are they matted together, large in size, or otherwise, and are they tender? So first we need to see the examination of the medial group. So if you can see here, the medial group of the nodes lie just under the pect major for fold on the anterior side. So if we're going to examine it from the front, so you need to examine it from the front end, and you palpate all the lymph node on that area. Okay, let's resume with the part that we so with the let's resume the part with the axilla. We need to know the n, so it is going to be n naught, n1, n2, or n3. So we need to know what are these according to the IAGCC criteria, and we need to know what are the causes or the common causes of a positive axilla. What if the patient has tuberculosis? What if the patient has some infectious mononucleosis? And so there would be lymph nodes would be there, and we need to differentiate them. These lymph nodes, because of inflammatory causes, need to compare them with malignant causes. So N1, N2, and N3 if they are malignant. And maybe you need to know about the lymphomas. So rubbery consistency, they are large in amount, well discrete. Tuberculosis, they are matted together. There are other symptoms. Patient has history of contact and everything. So we need to this all these things in my mind. So I go and inspect the axilla for any fullness first. Once inspection of both axilla is done, you need to ask the patient to raise the arms and examine both the axilla. And now you need to palpate each group. When we're going to palpate each group, so first of all is the medial group. So the easiest way to do it, I'll show you in some way of the videos when we'll be actually showing you the exact demonstration, that you shake hands with the patient. If your right hand is shaking, is you have extended your right hands to shake it with the patient's. So patient's right hand is, that means if your right hand is now booked, so only have a left hand to examine. So it's only the left axilla that you can, the right axilla with your left hand you can examine. You are not going to examine the same axilla with the same arm. Do not examine the medial and the anterior and the central and the apical lymph node with the same with ipsilateral hand, right? So it has to be done with the contralateral hand. So right axilla of the patient, we need to examine them with the left hand, and the left axilla, we need to examine them with the left axilla. So we need to examine them with the right. The best way is just a shake hand. Can you shake my hand? You shake hand, the whole your hand, the hand, patient's arm in your hand, and now you can easily examine the axilla with the opposite hand, which is now free. First of all, what we need to do is to just examine when you need to do the examination of the anterior fold. If you do the examination of the anterior fold is just under the pec major muscle. You examine that area under the muscle and palpate whether there is a swelling or not. One simple palpation, anterior node, so whether there is a node. If it is there, so they are discrete, rubbery, large, matched together. They are hard, irregular. If they're hard and irregular, then you'd say whether this seems to be a malignancy or a tuberculosis, but it has to be proven through histopathology. Second is the apex, right? So from here we move on to the lateral. On this, I will discuss in a bit later, because for this you need to change your arms. So you complete the examination for the medial, for the apical, and the central, and then you change the hands again. You ask the patient to hold his arm with the opposite hands. So the right arm of the patient, you hold it with the left hand, and now your right arm is free, and now you can examine with the right hand with the opposite side of the lateral side of the arm. Then the central and the for the apical part, you need to just put your hand just under the axilla, opposite hand, right axilla, left hand, right axilla, left hand, left axilla, right hand, along the floor of the axilla. You put it there with the in the middle side of the axilla and ask the patient to just fold the axilla, the arm, and bend on that side. Now this is the point when you can palpate with the fingers. You move up you push your fingers up. Don't be too harsh, and you go and palpate the central and the apical lymph nodes. So this is how you are going to do the axilla, and then move on to the supraclavicular and the infraclavicular lymph node. So you need to palpate the supraclavicular fossa for any first for any fullness, and then you need to palpate the area for any mass on both sides. Then is eight. If I recollect, so one was nipple areolar complex. There are four quadrants. Five, six was the axillary tail. Seven was the axilla, supraclavicular, infraclavicular fossa. Eighth is the inframammary fold. Do not forget to inspect first and then palpate the inframammary fold. There can be distended vessels, superficial thrombophlebitis, a previous scar mark, a discharging sinus, a small wound, or a lump there, which you cannot see while the patient is sitting, and it is there under the inframammary fluid. Again, remember to examine both axilla. I would also suggest at this point that you ask the patient to raise the arms again, both the arms up when you raise the both arms. So there would be, if there is a lump in the lower quadrants or is hidden by the inframammary fold or the fold lower quadrant, so now you'd see puckering and asymmetry, which is very important, and this will give you very good idea, and you are certain to identify any small area of asymmetry in the lower quadrant and around the inframammary fold. Ninth is the lymphedema. So we need to ask the patient to sit down and inspect both the arms. When you sit at the back, just take a step back and look at both the arms and see whether there is obvious change, difference in the circumference, and if there is, so you need to always measure that area using a measuring tape from two bony prominences. So it can be 15 centimeter from the olecranon, or it can be 15 centimeter from the head of the humerus, or any bony prominence that you feel like is easy to see in that patient. You need to compare it with both the sides. This is specifically important for postoperative patients after mastectomies and axillary lymph node dissections, and number two, in patients who have advanced diseases with foot axilla, where lymph nodes have actually been invaded by metastatic cells and the lymphatics are destroyed. What happened now? So we have completed the inspection and palpation of this. So remember, whenever you are going to examine the breast, there is a command, examine the breast. So remember, there are two breasts, so you need to compare both of them. And there are 10 things that you need to remember to inspect and to palpate. For inspection, again, I would say you find that there is a lump in the upper quadrant or lower inner quadrant or any other quadrant, even the axillary tail. Whenever you get this schema, you're running with 10 things. Suddenly, there is a box pops out. This I just mentioned that, and you need to complete the examination of the swelling now, each quadrant. So if there are 3 swellings, you need to complete it. You follow this, do it for 3 times. If there is a lump and there is an ulcer, so again, you need to repeat it. One schema, one box out, complete examination of swelling, and another box out for complete examination of an ulcer. And that gives you the full idea. So in case of swelling, you need to complete all the 4 steps of inspection, palpation, not auscultation really, and then percussion. So for the inspection part, what are the 5 things you need to see for a lump that was there in any of those 10 areas that you have mentioned? And specifically the first 6 parts is you need to see the site exactly. This is for example, this is the upper outer quadrant. Then you need to size. So this is on inspection, would say the size is of that of a peanut, is that size of seems to be size of a golf ball, or a pear or a small apple, and it depends upon what kind of, or the whole of the breast is involved and size of a small melon, whatever it is. You see? So this is your imagination, but it has to be of some characteristics, standardized. Next is the shape. So we need to know it's an irregular swelling. It is regular swelling. Then we talk about the surface. Is there any puckering? Is there any indentation? Is there any previous scar mark? Is there any wound associated with this? Or with that swelling, there is an abnormality in the structures. There are distended veins around it. There are multiple nodules on the skin. There is discoloration. There is ulceration. There is scaling. So all these things would come in the inspection of the 5S and the structures. So we see anything else, you see another scar there, you can see a fold, you can see thrombophlebitis. All these would come with that specific swelling. Same things, now you're going to do the palpation. You're going to palpate the area for any temperature and then tenderness. Ask the patient for any tenderness and just press it. If there's the tenderness, you need to be very careful, more favoring either an inflammatory process or an advanced stage that it has stuck to the underlying muscles. So that is the second. Site is important now. So it is, you need to give exact location. It is 3 centimeter, it is 5 centimeter, it is 2 centimeter from the nipple areola complex, it is depth, it is close to the skin, it is attached to the underlying muscles, it is fixed, it is mobile, it is fluctuant. So everything that is going with the site is important. Second thing is size. Now you need to measure it using a measuring tape and give 3 dimensions that I mentioned. So it has to be at width, breadth, and height, which cannot be. So a 5 into 5 centimeter blocks can be this height, and a 5 centimeter height can be this height. So you need to add height to it. So 5 into 5 into 4 is examined. And then again, you need to know the T classification so that now you are labeling it that this is a T3 lesion on examination on T. Third is the shape. It is regular, irregular. It is the how does the surface is smooth. For fibroadenomas, it is bosulated, it is irregular, it is hard, it is the distinct margins, all for malignancies, and then the surrounding structures. So you need to see the inframammary fold, pinching of the overlying skin, fixity again to the underlying structures. There is any extension of this into the nipple area complex, any expression of pus or milk or blood or any secretion when you press this area with the nipple areola complex, and this would all come into any distended veins, any previous scar marks, and come with the surrounding sectors. Next is to add to this, you need to know the consistency, the compressibility, the margins, the mobility, the fluctuations, fixity, reducibility, pulsatility, and all these. So this completes the examination of the inspection, and then you need to complete all these. So you need to complete all these again. On inspection, you need to know if there is an ulcer. So we complete the same, right, the same schema again. So you need to size, shape, surface, surround structures, edges, margins. So here you see the important thing is that if you see this one, the margin for the swelling changes into edges. And another change that's there, you need to add floor to the examination. So floor and base are two things. Floor you can see, base you can palpate. It is like the furnish of a building that you can see is tiled. There are stones, there are chips slided in them, there is a carpet in them, and then there is a base or the bunyad which you cannot see, and it's being built by God knows what these things, but it is not visible. You can only palpate it. So these two things you need to palpate. So to summarize what you have already done, when you have done the 5 things with the breast is a nipple areal complex, the 4 quadrant 5, axillary tail, axilla, suprainferior fossa, and the lymphedema. And the 10th thing is distant metastasis. For distant metastasis, we need to auscultate the lungs for any abnormality, for any crepitations, any shortness of breath, usual excessive muscles of the patient. There can be pulmonary effusion. So you're thinking of the patient is can have a metastasis. So they usually present with pleural effusion. So there would be no air entry inside, And for if you're thinking about tuberculosis, so there would be fibrosis and would be pulled on the other side. Liver would be enlarged. There can be ascites. There can be jaundice in the patient on physical examination, and you need to palpate the liver just under the edges of it. Once you are done, when you have completed this examination, now you are good enough to identify the T. So it can be less than 2 centimeter, 2 to 5 centimeter, more than 5 centimeter, or it is a wound, or is it fixed to the underlying scales and muscle. The N, the no lymph nodes, or there are lymph nodes, the solitary lymph node, and they're easily mobile. The two matted together are N2, and suprainflexible fossa, or opposite wrist, opposite axilla is N3, and then the metastasis and abscesses add to the spine also. So this completes the examination of the breast. We will be in our next session. We will be talking about the actual examination, and I will be sharing a link in which we can use this area, use this presentation in with the help of the other one, so that would be able to complete the examination, and that would help us. Thank you very much for watching this video.